the screen before
the first slide. So today we're going to talk about reimbursement, which is a little bit farther down the journey. You guys are talking a lot about regulatory and a little bit about raising money, I understand, and some other aspects of being an entrepreneur. But at some point, you need to think about reimbursement. And actually the point is right about now. You want to be thinking about reimbursement when you were first developing your company and your organization. But I don't want to start with that. I want to start with grocery shopping.
Okay, sorry, let me just make sure. Remy, we're good, right, on your end? You can see the slides of it?
Where do you go grocery shopping? Costco, what about Costco? You have a car to get there, and you got a membership. There's certain things you need in order to get to a Costco.
Yeah, so my parents helped me reimburse.
You go shopping. Costco. I love Costco. Favorite place. Where do you go shopping? Costco. Loblaws, I like Loblaws, yeah. Any others? Where else do you go shopping? Farm Boy. Oh, high end. Okay, all right. Any others? No frills, that's it. Yeah, no frills. Are you ready to go?
Yeah, ready to go.
Okay.
You're welcome. If you don't mind actually standing over here a little bit, it's just the microphone for the
microphone is there.
You're welcome to wander a little bit.
And where is the camera? So that, because
It's actually here, so it's gonna be kind of the side of you.
okay.
Sorry, that's the setup.
No, that's all right.
And just, yeah, you can. Just the little, yeah, the arrows.
The arrows.
The only, oh, sorry. Yeah, it's over on this one. Yeah, that's the fun of it.
Food basic, how about food basic? Now, why do you shop at Farm Boy?
It's too closer to my house.
Close to your house, okay, yeah. And why do you shop at No Frills? Close to your house, yeah. What about price? Anybody interested in price? That's why I don't shop at Farm Boy. And I don't shop at Loblaws. Who shops at Loblaws? What, is it proximity?
Like, I don't know, just I know how to get my way around. So.
Okay, you're familiar with it?
Yeah.
Okay, it's interesting, yeah.
It's also harder to buy at Walmart. Like the experience is also different, so it very much depends on whether you want to buy it as well.
Tell me about that experience.
Yeah, so in Walmart, for example, you cannot buy a lot of pre-made food, right? Like or ready to bake or ready to do stuff. So if you want to get something that is more readily available, you go to one of those fancy places.
Right.
They have a salad bar, which is okay. I mean, I never buy them.
Right.
When I go to Walmart, everything is just picked up, and I don't like it.
It's an experience there.
It's an experience.
It's like, man, I've arrived. You go to Walmart, it's kind of like, yeah, I'll kind of sneak in and sneak out. Yeah, it's interesting. Because they kind of sell the same thing, right?
Yeah.
They're all selling food.
And it's way cheaper to buy at Walmart.
And it's way cheaper to buy.
But it's also farther. Like I have to go to the Dufferin Mall, which takes me 20 minutes, and I appreciate my time.
Yeah.
Going 5 minutes from my house instead of going 20 minutes. I value my time.
This is great. And why the hell are we talking about groceries? We're talking about it for two reasons. One is it gives me a nice little visual lead into the reimbursement basics, because I've been asked to do this in 20 minutes, I think in 10 minutes some questions. So this is a real rapid fire reimbursement. The other piece is that discussion really is at the heart of reimbursement. So if you don't take anything else away from this conversation, just take that interaction, on grocery shopping. Because in that example, you guys are the payers. You're the one paying, and the grocery store are the ones that are on. They're the medical device company in this analogy, right? They're offering you something. And I didn't hear a lot about price. What I heard was value of time, proximity, familiarity, variety, ability to buy different things, experience. Those are all value, pieces of value, which don't necessarily relate to price. So as we go through these few slides and have this discussion, I want you to think about that assessment that you have made to go to Farm Boy as opposed to Walmart. Those are two perfect extremes. What made you make that decision? It certainly wasn't price, because the price is cheaper at Walmart. There were all these other things that you saw value in. And that's really the key to reimbursement, is to demonstrate value to those who pay the bills. So let's get into this. What is reimbursement? Somebody give me a definition for reimbursement. I don't think you can answer. You're not allowed to answer. You've seen these slides before. What do I talk when I say reimbursement? What the hell does that mean? Anybody? Yes,
Getting money back that was spent,
I'm sorry.
getting money back that was spent,
Yes, now who's getting money back and who's spending?
someone spending and then getting the money back from some external source that's gonna give that money back, we agreed to give that money back.
That's the technical definition of reimbursement, so you're absolutely right. In the context of medical devices, or drugs, or vaccines for that matter, it's somebody other than the patient is paying the bill. So if we think about the nomenclature, we talk about patient pay, that's the patient is paying, and reimbursement means somebody else is paying. And that's primarily governments. We have a public system which reimburses drugs and medical devices to a certain degree. We have a private system as well in this country. Now, if we're going to get reimbursement, if what we want is reimbursement, we want somebody else to pay. If we want the government to pay, we want the hospital to pay. We need a customer for our medical device. We got to figure out how to get that reimbursement. And this is the basic reimbursement model to ensure that you're on the right track. Okay, so where do we start? We start at the bottom of the foundation. That's Health Canada approval. You guys have done regulatory. You've done regulatory stuff, right?
So asynchronous lecture that they had to do for today.
Okay.
It's fresh.
So you've got your class 1, your class 2, you decide which class you've got your submission, you got to get your medical device establishment license, all of that sort of stuff. That's the Health Canada saying, yeah, you can sell your product. That's foundational. Now on the top of it, you need some health technology assessment. Now there's a formal health technology assessment, and then there's an informal health technology assessment. Now, health technology assessment is exactly what we did a few minutes ago when we applied it to groceries. So we did a grocery store assessment, and this is a health technology assessment. So you're assessing the value for money. What value do I get for the dollars that I'm spending? Asks the payer, the government, the hospital, and so on. So that's the foundation. You got to have some kind of either informal or informal health technology assessment. Something to say that I've got some value for money here. Okay, so then on top of that, we have 4 pillars. You get the idea here. The stronger the pillars are, the stronger your case for reimbursement. If you've got weak pillars or no pillars, you're going to have a real problem getting reimbursement. And there are 4 pillars that I think are primarily important. There's some other things as well, but these ones are primarily important. I'm going to start on the left, which is value offering. We've just talked about that in some ways. We're providing. Well, let's use an example. Who's got an interesting medical device innovation that they're working on? Anybody want to put theirs on the table as an example? Nobody? Okay, I'll throw out Alcon is an eye care company.
I'll go.
Okay, you go, yes.
But I'm not sure, it's not a medical device, so maybe it's not.
Okay, just.
It's an application.
Sure.
It's an application to estimate the risk of mortality in pregnant women,
So,
cardiovascular mortality.
so it's an assessment tool.
It's an assessment tool for readily available product of our research algorithms.
All right, so value offer. Who cares? What do I get?
Yeah, so 4% of the women in the United States and Canada and worldwide die from cardiovascular diseases during pregnancy is the first reason of cardiovascular death or death in non-obstetric death worldwide. And with the ban of abortion in United States, I mean, they should be pretty on top of this thing. So I think people should care about women not dying.
So we care about women dying, but am I gonna pay for this?
Yeah.
So then why am I gonna pay for it? What do I get? If I give you money. I go to Farm Boy, I get my groceries, I pay you money. What am I getting in return?
A facilitation of the assessment of the risk. Let's put it that way, just so you can identify the woman who's at risk of dying, and then you can act on that if she doesn't die, and then your mortality will reduce and
Identify a patient at
you're a
risk.
good country, right?
Yeah, you identify a patient at risk and then you're able to do something. You're able to follow that person more closely. If you're low risk, okay, you're fine, go away, don't worry about it. You're high risk, we need to follow you very closely. Okay, there's some value offering because by extension, you're gonna save lives, right?
Yeah, yeah.
These patients aren't gonna die if we can identify them and treat them appropriately. Okay, that's fantastic. That's a value offer. Okay, now I'm a payer, you've got my attention. Okay, now my second question, so that's the value offering pillar. So really, if you think about any startup or any innovation, you've got a problem and you've got a solution. Okay, and it's the space between that is the value offering. So what's the problem? What's the current standard of care? What's the problem with that standard of care? What are you offering? And that gap between those 2 points, that's your value offering. If it's a nice big gap, if it's a nice big value offering, then we're on our way to reimbursement. So we're going to identify some patients, make sure that we save their lives. So that's a nice value offer. The second piece is the strength of data. Okay, show me, prove to me, what data do you have?
Multiple studies, validated, largest cohort of patients.
Fabulous, you got lots of strong
Yeah,
data.
I haven't validated my device, right?
Okay.
So I think I have to go through all of, it's not a device, so the application I have to.
Concept is validated,
Concept.
device isn't. Okay, so you still have some work to do on the strength of your data before you go into a payer and say, you should pay for this because, this is what you'll get. You've got to have that data to support. So that's your on your way. So great. So we've got the strength of data. And now we're going to go to level of advocacy. Anybody want to take a stab at what I mean by level of advocacy? Who's going to share from the rooftops that this is important, other than you? Right? So we'll talk about stakeholders and what stakeholders are and how they can help shout from the rooftops. And that's really the central piece of that pillar. If you've got other people that says that this is really important, then that pillar is nice and strong. Support or alignment with government priorities. There's a rare disease strategy that the federal government announced a year ago, but nonetheless, they announced it. They put $1.5 billion towards that. So if you intersect with rare diseases somehow, interesting. You're aligning with one of their priorities. They have a strategy, which means they're willing to pay money. So again, the larger, the stronger that pillar, the more control. So that's the basic model. We're looking for somebody to pay here. We're looking for somebody other than the patient, maybe, and we'll get to that at the end. But for the time being, we'll talk about that government entity, the government entity or the private insurance company paying. And we have these 4 pillars: value offering, strength of data, level of advocacy, support with government priorities. There are a few other pieces that you have to, there's some roadblocks you should be aware of. There's the old resistance to change, there's natural biases. You've got the billing codes, we'll talk about that in a minute. Sometimes change is not in my interest as a physician or a healthcare provider. If your AI was going to put radiologists out of business a few years ago, I don't know if you remember that. So if you were selling one of those AI devices, probably a little bit of a challenge getting a radiologist to be your champion. As it turned out, that was completely wrong. And we need more radiologists than ever. They're just a lot better at what they do. I'm sorry, let me just get this on. There we go. Okay, so I want to focus on the first part, which is strength of, oops, sorry. So the first part we're going to talk about is the first 2 pillars: value offering and strength of data. And that's the really important piece there is the health technology assessment. Okay, so we did that grocery store comparison. On groceries, they do the same thing here. It's gonna be a little bit more complicated, and there'll be some nomenclature that you're gonna want to know, so you can be one of the cool kids when you talk about HTA, health technology assessment. And so we're really determining the cost of the system versus what the patient gets. That's the value for money, right? Okay, so we have an x-axis and a y-axis. On the y-axis is increasing difference in costs. So the cost of intervention A versus intervention B. That's the problem solution concept, right? The problem with the current standard of care, that's A, and what we have developed is B. The difference in cost is measured on the y-axis. Then on the x-axis is the increasing difference in effectiveness. So the example of that was used with the risk assessment. We're assuming that that is a lot more effective than not using a risk assessment. So that is measured. And then you have 4 quadrants here. So if you put a little cross in the middle, number 1 is a situation where your innovation is more money, it's more expensive, but it is also more effective. So it costs more money, but it's more effective. Okay, and that's probably where you want to be, right? Because it's an innovation, you want to be solving a problem, so you want to be in that square. Number 2 is you cost more money, but you're less effective. That's probably not a good place to be. Intuitively, you understand that if you're going to pay more money for something that's less effective, you're not going to go there. Number 3 is less money, less effective. That's a bit fuzzier. I'm going to pay less money, but I'm going to get less value. I don't know what I'm going to do with that one. And then number 4 is less money and more effective. Oh, that's a dream place to be. You're telling me that you cost less, but you're providing more value. That's an easy one, right? So what health economists do is they take a line and they draw it right through the middle, and they arbitrarily decide that the top of that line is not cost effective, and the bottom of that line is cost effective. Quadrant number 4, less money, more effective. Well, of course that's going to be cost effective. We all know that. Similarly, if you're more money and less effective, quadrant number 2, of course you're not going to be cost effective. So it's these number 1 and number 3 where it gets a little more difficult. And again, most new innovation sits in quadrant 1, more money, more effective. Now what do I do? Is there value here? Is there value for my money? That's the determination that the health technology assessment does. I won't go too much into this. Suffice it to say that there are some, you may hear some terms being tossed around: incremental cost effective ratio. That's an ICER, it's known as. So if you hear people talk about ICER, that's what they're talking about. You can get cost benefit analysis, you can have cost utility analysis. If you get into this, you'll hear people talk about quality adjusted life year. And that's an economic measure that health economists have figured out in order to determine whether something is cost effective. So how much money do I pay for a year of perfect health? So that's what the quality adjusted life year means, also known as quality. Given the time, we'll skip right through that. I will note that from a medical device perspective, health technology assessment is all over the place. This is the formal stuff, is all over the place. So oh shoot. From Stan, what's this from? Gravity Falls. Thank you, Gravity Falls. Who's watched Gravity Falls? Love that show. Watched it a ton with my son. In the back of Russell Stan's place is a bottomless pit. And so if you've seen that episode, you know exactly what I'm talking about. I think there's only one person who has. So the point of this is that there really is a bottomless pit of health technology assessment in this country. You'll want to know too, there's CADA, which is the Canadian Agency for Drugs and Health Technology, and there's Health Quality Ontario. Those are the two big ones. So the important piece here is really to keep health technology assessment in the back of your mind as you're developing that medical device, that value for money concept. There are other pieces that are important as well. Is there a current fee code for a physician to bill for the use of your medical device? Is it training required, infrastructure requirements? Is there an impact on someone's livelihood? We talk a lot about it in the full course that I teach, a lot about what is the impact, measuring your impact. And really, that's so important, because if you understand exactly where your impact is on all the different stakeholders, you'll get a much better sense of where your gaps are. So let's go back to achieving. Any questions, by the way, on health technology assessment? Super fast overview, but value for money, right? It's the benefit that you get from going to Farm Boy as opposed to Walmart. You're paying more. What am I getting, right? So level of advocacy. So this goes back to understanding your impact. I developed this concept of a wheel of influence. I call it a wheel because each of these groups are connected to the decision maker, the person who's going to be making the decision as to whether to pay for this medical device. It's the hospital, the government, whichever organization. But those groups are all connected to each other as well. So in the healthcare system, there's basically 6 buckets of stakeholders, and these are the people that are they going to shout from the rooftops about your medical device? These are the ones that are going to determine the strength of your pillar of advocacy. Okay, so let's start here. So we've got politicians, political advisors. So this would be like the Minister of Health. This would be a senior policy advisor to the Minister of Health. The politicians are determining the policy. And if your medical device somehow intersects with the policy side of government, politicians are going to be very interested to hear. Prenatal cardiovascular death is probably something they'd be interested in. So there's a political side, but then there's also the bureaucratic side. So there are all the bureaucrats running the Ministry of Health. They might be a stakeholder as well. Key opinion leaders. Who knows what a key opinion leader is? Someone give me a quick definition. Almost self-explanatory. This generally refers to physicians, and they're the type of guys that write the papers. They're up at the podium. Their other physicians look to them to see what they're doing, and then they will follow. They're key opinion leaders. And healthcare professions, HCP associations can be very useful as well. If there is a let's skip over that. Media goes without saying that can be a very important stakeholder. Keep an eye in the papers or the news feeds. The papers, how old am I? Keep an eye in your news feeds to see stories about maybe like a cancer medication that's not reimbursed. If there's a story about disparity in reimbursement in medical devices, those stories will likely come back to somebody and a company who is trying to develop a medical device. So the media can be a very important player in here. Patient groups and advocates. If you name a disease state and then type in patient group, you will find an organization. That's how prevalent they are. So every disease state, every therapeutic area will have a disease group. And that means you have patient advocates. So if you're looking for people to say, this is freaking great, and government, you should pay for it. I mean, there's no better place than to go to the people that are actually impacted, right? The patients. Economic stakeholders, things like chambers of commerce, that kind of thing can also be useful. So when you're thinking about your medical device, you have to think hard about who you're impacting and who are these stakeholders. Where might there be an intersection? And when there's an intersection, you have a potential advocate. And if you have a potential advocate, then you have an opportunity to strengthen that advocacy pillar. Make sense? Last one is support with the government alignment. I breezed over the political side and the bureaucrats very quickly, but yes, sorry, I was going to ask you who that is, but you're not going to be able to tell me who that is. But I will tell you that even if we move that picture, you still wouldn't be able to tell me who that is. But you can tell me who the person over there is, right? Who's that guy? That's that for it, yeah. This person here, it's fine covered up, you'll never guess who they are, but arguably the most important, powerful person in the Ontario government. What is her name? It's Emmanuel. See, I don't forget. She's the head of the civil service, so she's the head of the bureaucracy, and Ford is the head of the political side. Just to highlight that there is a difference between those two. So if you're looking for that advocate, and you want to understand the intersection with that potential advocate, you need to understand which side you want to go after. So people talk about the government, the damn government. They treat it like a monolith, but it's made up of thousands of people, individuals. And on the political side, there's about 1,000 that run the province. They're the ones that get elected and tossed out, and their staff. And then there's the people that are actually running government, which is the bureaucracy. So if it's a policy piece, like we should measure the, we should do a risk assessment on prenatal moms, that's a policy. The bureaucracy will be the ones that will put that into legislation, they'll make the regulations, they'll do the implementation of policy. So you have to understand it's a policy issue or an implementation of policy issue. Any questions on that? That's the fastest government relations session I've ever done. So we're back to here. And again, value offering, strength of data, level of advocacy, support with government. That's how you get reimbursement. Now the other, how much time do I have? Am I
You're running on fumes, but
I'm running out of fumes.
you've got the rest of the lecture time, so.
Yeah,
Okay.
so that's kind of the theoretical piece. There's some practical pieces about how medical devices are purchased, are requisitioned. I think where do I want to focus? Just take a second here. So if you follow the money, that's often a good way to do it. The vast majority of medical devices are purchased through hospitals and long-term care facilities. Okay, the vast majority of those are requisitioned through group purchasing organizations. Group purchasing organizations buy in bulk in order to drive the price down. So just understand that most medical devices go through a hospital long-term care, and then most of those are actually purchased via a group purchasing organizations. But that may not apply because there are lots that don't. There's direct government reimbursement as well. So there are programs like the Assisted Devices Program, anything involving home care. For example, any medical devices involving home care is through this program. So there are individual programs. The naloxone kits, if you go to pharmacy, you can get free naloxone kits. Somebody's paying for that. It's the government is paying for that through that program. So that they're completely reimbursed. There's also some alternative payers. You've got private healthcare organizations, allied health professionals, private insurance companies, regional health authorities, hospital charitable foundations, private donors, direct to consumer. There's all kinds of different ways of reimbursement. Don't forget billing codes. Don't forget billing codes. If your medical device is used by a physician, then they will get paid to use that medical device. In order for them to get paid to use that medical device, they have a billing code. So they say, hey, government, here's my billing code because I did this with this medical device. You don't have a billing code? They can't bill for their time. If they can't bill for their time, they're gonna be less inclined to use your medical device. Billing codes, if it applies to you, is important. And then the last question I'll ask is, do you want reimbursement? So you need to actually ask that fundamental question whether or not you need reimbursement or not, because what's the downside of having government purchase your medical device? Anybody? Bulk purchasing means your price is going to be less. You can sell directly to a consumer. You're going to get more for the medical device. You're going to be commercially, you're going to be more successful, but maybe you'll sell less. And it all comes down to those. Okay. From a pharmaceutical perspective, blood pressure medication, no one's going to pay for it. You lower my blood pressure, what do I see? I don't see anything. I feel fine. I felt fine before. In fact, now I don't feel as well because I got the side effect from the blood pressure medication. No patients are going to pay for that. It's a pain medication. Willingness to pay is quite high, right? Okay, think about it. That was a speed lecture on reimbursement. So any questions? Yes.
But I So this kind of outlines the success rate of the device, not necessarily creating that, but its ability to be the worst place. So I'm wondering, what would be the main difference? Would this still apply if we're looking at the ability of medical device to be all these? It's not focusing on institutional value.
The reason this is important is that if you have a medical device, which patients aren't going to pay for, but governments will, this is your only pathway to revenue. So if you're unsuccessful here, you fold up your tent, you go home, because there's no commercialization, there's no revenue. Right now, there are some medical devices where there is a greater propensity for patients to pay, a greater interest for patients to pay. And so it could be that this is not as important. But for most medical devices and for most drugs, this is absolutely essential. Most vaccines, if you don't have reimbursement from the government and private insurers, you're dead in the water from a commercialization success perspective. Does that make sense? Yeah.
I would imagine that there's still an overlap between where the expenses are if you're not worried about
If you're not worried about reimbursement, there's still the value offering and strength of data. We had that example of us choosing a grocery store. That's an individual payer that's making a value assessment. We do that every day. You know, to buy a Samsung, to buy Apple, or it's everything we do. Every time we're putting it in our wallet, we're doing our own internal equivalent of a health technology assessment. So yeah, yes.
Some companies have to go through the same process to get it approved by OCAN, let's say.
So it is exactly the same model. The process slides I showed you were completely different, but it is the same. It is the same model. Yeah, you got to have healthcare approval. The health technology assessment is formalized, so you have to have health technology assessment, and there are bodies that will actually do that, and then those pillars are exactly the same. And for vaccines as well.
I'm thinking like about Ozempic, for example, as like a medication that has been approved in the United States for weight loss and using cardiovascular death, and then when we get to Canada, it's been in the market for quite some time, and yet it's not approved. So I think
Payers are terrified of that. Are you kidding me?
how long is that, like, how long does that process actually take? Because it's been taking them a while to do it.
So the average these days, I was just at a conference and they were talking about almost 2 years process from Health Canada approval to actually having reimbursement, and that's just the average. But the Ozempics of the world, they're terrified of, because those are like massive budget impacts, right? Oh my God, I don't have that money to pay for that. So, yeah. Yeah, the whole drug side is another interesting. It's another half dozen lectures.
Can I jump in?
Please.
Ask some questions?
Yeah.
Absolutely fabulous presentation. Thank you very much. It was very well. It was perfect for where the class is now.
Good, thanks.
So some comment maybe on level of advocacy, and the reason is because the startup one of my startups from was a talk from last week. Spencer Waugh came in to talk about our product, and it's a medication delivery device. The biggest challenge we had was exactly what you just said, which is time to get to reimbursement. And you need these 4 pillars. The challenge, of course, is we didn't have payers, right? Because no one wanted to pay for it. So we had to go to Europe to get our first clients, because Europe, the government was subsidizing. So in your experience, the level of advocacy, how do you get advocacy if no one's buying? So let me explain a little bit more. These guys are all, new entrepreneurs and startups. And of course, the first thing you want is revenue. And so to get advocacy, and the government looks for it as well, is you do need interest, correct? And so if you have primary care support, that's lovely. But even primary care support, they're going to want to hear about how it's being used or whatever. But so you know what I mean? It's kind of chicken and the egg.
Yes.
So in your experience, how do you address that? As a startup,
You want to find some key opinion leaders. That's the place to start, because they are influencers, right? It's akin to finding somebody on TikTok for a commercial or a consumer product, right? These are the guys that are going to be educating other physicians. They're going to be speaking at the podium. They're going to be writing papers. They're going to be writing editorials. So if you can get them enthused, then you're going to be able to get the hospital enthused if it's a hospital product, or you're going to be able to get general practitioners. If you're raising money, the venture capital groups and the angel groups are going to look at who are on your slides. If there are no key opinion leaders, if there are no physicians on your slides, they're going to say, thanks very much for coming. Right. So there's a lot. That's the short answer is you got to find and start where you can. Introduce the product and try and get them excited. But on decks, I see decks all the time, and on there, invariably, the good ones, there will be maybe not key opinion leaders, but there's certainly physicians, healthcare professionals in the space.
any other questions? Mark, no? Okay, well, thank you very much.